Good morning, everyone. Greetings, greetings. My name is Andrea Jenkins, and I'm the Strategic Partnership Lead for Social Mission Alliance. We welcome you to welcome and introduce our Dean of the Milken Institute School of Public Health, Dr. Kelly Jibo. She wasn't able to be with us today, but she wanted to personally greet everyone, so she recorded a video message, and we're going to cue the message now.
On behalf of the Milken Institute School of Public Health, I'm truly delighted to welcome BlackDoctor, our distinguished guests, and colleagues from across the country to today's Thought Leadership Summit. We are proud to host this convening here at GW, with BlackDoctor and the Social Mission Alliance, a vital part of our Department of Health Policy and Management, and the Fitzhugh Mullen Institute. Together, we are working actively to advance healthcare equity and strengthen the future of our health workforce. I want to extend my sincere thanks to BlackDoctor's CEO, Reginald Ware, and President and COO, Aki Garrett, as well as the leadership team for their partnership and vision in bringing together this important conversation. I also want to recognize the steadfast support of President Ellen Granberg and the university leadership, whose continued commitment to public health and equity makes convenings like this possible. We are at a pivotal moment in healthcare. The challenges are real, but so are the opportunities. It is critical that we remain focused on building a workforce that is diverse, well-supported, and equipped to serve every community that we serve. This means strengthening pathways into the healthcare professions, supporting learners and professionals at every stage of their journey, ensuring that policy and practice are aligned. Today's summit is more than a conversation. It's an opportunity to identify actionable strengths to move this forward. Everyone in this room represents a building block towards a more equitable, responsive healthcare system. Thank you again for joining us, and welcome to the Milken Institute School of Public Health.
And now I have the opportunity. To introduce the Executive Director of Social Mission Alliance, Dr. Toyoshe Oyemi.
Hey, good morning, everyone. All right. It's great seeing everybody. Thank you, Andrea, for that kind introduction. It is my honor to welcome everyone to the 10th Annual Top Blacks in Healthcare Thought Leadership Summit and the 11th Annual Awards Gala this evening, hosted by BlackDoctor. Social Mission Alliance is proud to partner with BlackDoctor around our shared value of spotlighting. We're going to do this instead. Social Mission Alliance is proud to partner with BlackDoctor around our shared value of spotlighting and supporting exceptional leaders and innovative practices in the health workforce and health professions education, particularly those who are focused on closing the most persistent gaps that we see in health outcomes. So it's really only fitting that this evening in particular, BlackDoctor will be honoring 15 groundbreaking history makers and trailblazers in healthcare. But beginning here, can you hear me okay over there? But beginning here this morning in a really beautiful day here in Washington, we'll be discussing topics that are really most relevant to the communities that we're accountable to and that we're responsible for. Some of those topics include heart health, oral health, sickle cell disease, along with the preventable conditions that are associated with these that disproportionately impact people and communities of color. So we'll be discussing the workforce. We'll be discussing the role of rebuilding trust between our communities, science, and medicine. And most importantly, this day is really about storytelling, and that's particularly important because we know that there's a lot of power in narrative. Also, we'll be celebrating the incredible achievements of Black doctors who are national leaders in the advancement of care, research, and education. Thank you to all the partners who made this possible. Thank you to the George Washington University Milken Institute School of Public Health for hosting these conversations. Thank you and welcome home to Dr. Ashanti Carter, who is also an esteemed member of the SMA Advocacy Advisory Council, and to BlackDoctor for being able to establish this platform, offer this platform to advance health equity in a really meaningful way. And of course, thanks to each of you for taking the time to being a part of this moment of celebration, of learning, and of service, and certainly of reflection as well. So welcome, and let's move forward together. It is my honor to welcome Aki Garrett of BlackDoctor.
Thank you. Good morning, everyone. So on behalf of everyone at BlackDoctor, welcome to and thank you for joining us at our Thought Leadership Summit. I'd like to give a special thanks to our sponsors, Novo Nordisk, UCB, Amgen, Vertex, and Novartis, as well as to our partners, Social Mission Alliance and Limitless Impact Foundation. Your partnership, your perspective, and the commitment to advancing better health outcomes are what makes gatherings like this not only possible, but meaningful. At BlackDoctor, our mission is clear. It is to ensure that every Black family thrives in health. We also recognize that achieving this goal is not possible without our partners and the content and all of the assets that we produce as an organization. And it also requires collaboration across the health equity ecosystem. It requires trusted voices, culturally fluent engagement, and a shared willingness to challenge the status quo in how we reach and serve diverse patient populations. So today is exactly about that. It's about honest dialogue, actionable insights, and bringing together leaders who understand that inclusive engagement isn't just a moral imperative, it's a growth imperative. The opportunity in front of us is massive, but so is the responsibility. Throughout today's conversations, we hope that you all will lean in, share openly, and think boldly about what's possible when we align strategy, science, and culture. Thank you again for being here, for your partnership, and for the role each of you plays in driving this work forward. Let's have a great summit. And with that, I'd like to introduce to you our co-hosts and our co-MCs for the day, Mr. Derek Lane, BlackDoctor Chief Marketing Officer, and Ms. Jade Curtis, our Executive Editor at BlackDoctor.
All right, welcome everybody. Welcome. Well,
I don't think they heard.
everybody's like, well, good morning on this incredible day outside. Can you believe that? It's going to be almost 80 degrees today, sunny, and we are enjoying just being here today. But Jade, we've got a power-packed day today.
Yes, we do.
Yes. So, without further ado, who do we have coming up first in our the first panel?
Oh, you were handing me the mic. Sorry. We're used to having two mics up here. My bad. But we are rewriting the narrative, empowering equity in cancer care. So this is going to be a really impactful and serious conversation about cancer.
And we have our illustrious Chief Content Officer, Kristen Vaughn here. Come on up.
Thank you. Good morning, everyone. So good to see everyone today. I'm so glad you're here. As Derek and Jade pointed out, this is an action-packed day, and not just action-packed, impactful. So as we start off today, I just wanted to welcome you. As Derek said, my name is Kristen Vaughn. I am the Chief Content Officer for BlackDoctor, and we are so excited to be here. I'm going to be your moderator for our first panel. And our first panel is Rewriting the Narrative, Powering Equity in Cancer Care. When we talk about cancer in the Black community, particularly breast cancer, particularly prostate cancer, we're not just talking about disease. We're talking about access, trust, and timing. And too often we're talking about missed opportunities, right? Despite medical advances, Black patients are still more likely to be diagnosed later and to die sooner. This is not a knowledge gap, this is a systems gap. Right? This is a systems gap. So today's conversation is not about what we already know. It's about what we're going to do differently. And everyone in this room has the power to help us move things forward and to move differently and to do things differently. We're joined by leaders who are not only shaping oncology, but have the power to help rewrite the narrative in real time. Let's get into it. All right, I'd like to call onto the stage fellow panelist Rodney Gillespie and Carrie Gober. All right, thank you. Thank you. Good to see you, Rodney. While we wait to get all mic'd up, I'm going to just kick things off. Why don't we start with you giving a little bit of an introduction about who you are and how you're here today? Oh, you have your mic. Okay, thank you. Yes.
All right, good.
All right, excellent.
Rodney Gillespie. I am the Senior Vice President for our theranostic business at Novartis. Well, it's actually a very
There you go. Let me hand this to you.
It says green, right? Let's see.
All right, you think that we can.
All right. Hello, hello. Can you hear me now?
Yeah.
Or I can just talk really loud. Hello, everybody. I'm sorry, excuse my back for those over here. Rodney Gillespie. I'm the Senior Vice President for Novartis for our theranostic about our ligand business, therapeutic and imaging perspective. It's around cancer care, specifically around prostate cancer. Oh, and artist for a few years. Okay, that's even better.
Yeah, there we go.
All right. Let's just
Hand it over to me. I'll take that for you. There you go. Perfect. There you go.
So I've been with Novartis for a few years, but I've been in the cancer space for a number of years, and it's an area that's near and dear to me. And we can talk a little bit more about the why behind it, but that's why I'm here, and I'm looking forward to the discussion.
We're happy to have you. We're happy to have you. Absolutely. Ready to kick things off. And Miss Carrie Gobert, tell us a little bit about who you are. Introduce yourselves.
Good morning, everyone. I'm Carrie Gobert. It's wonderful to share the stage with our partner as well, with the American Cancer Society, Novartis, as well as BlackDoctor.org. BlackDoctor.
BlackDoctor now. Yep.
Let me correct that. My name is Carrie Gobert. I'm the Chief of Staff of our research team at the American Cancer Society. I work with our Chief Scientific Officer to set forth the priorities for our population science team, our cancer screening team, as well as many of you may know that our team leads Cancer Facts and Figures, which is led by Ahmadine Jamal, but I work with all of those teams to make sure that our priorities move forward.
Great. Thank you. Thank you. So we're really excited to have you guys today. Let's jump right into everything. When we talk about rewriting the narrative, which is the theme for today's panel, what narrative specifically needs to be rewritten? We're talking prostate cancer, we're talking breast cancer. What is the narrative that needs to be rewritten? What needs to be disrupted right now? And what do we need to change in terms of how we think about these conditions? Sure. There we go. Make sure everybody can see. There we go.
Perfect.
Yeah, do you want to kick things off, Rodney?
Carrie, I'm happy
Sure.
to jump in.
I can kick things off. I actually wrote a couple of notes this morning, so I'm going
We
to
love
read.
notes. We love notes. Jump right in.
I'm going to read from my notes. Of course, many of you have seen Cancer Facts and Figures this year, and survival in our community is so damaging right now. I mean, we're at a global health crisis, honestly, within our communities. So the first thing that I thought about is accountability. We have to, our health systems, advocacy, access, those things that many of us, even Aki, mentioned earlier in the opening. But that is one thing that when you look at survival rates compared to other cultures across all cancers, as we look at the data, we're dying daily, every second. And so the one thing that I want to change the narrative, which I say to a lot of our scientists and epidemiologists as well, we have to come out of the lab. We have to go into the community to share the research that we're doing. Again, our team has to take more accountability, that when we're working on studies, also, I always encourage that we can actually have patients or the community involved in our studies, to help people better understand, as some of the other panels will talk about clinical trials and things like that. But if we are sitting behind our desk and sitting behind our screens, and me as well, not going into community to share the research that we're working on, then for me personally, not of the American Cancer Society, that's my NDA, this is Carrie speaking. But for me personally, if I'm not taking the research that I'm working on into the community daily or weekly or monthly, then I'm not doing what I need to do.
I love that. What I want to follow up with that on is, what is the response that you get from your colleagues when you say that? It sounds like you're committed to taking your research into the audience and to the community, talking to people, like you said, weekly, daily, monthly. That sounds like exactly what we need. But is everybody on board with that? Is that one of the things that we need to back up and work on with that from the other side?
Absolutely. I don't always get an excited response. And to be very candid and honest, even in our cohort study, Voices of Black Women, we had a number of people that were not, they didn't feel comfortable, or they didn't know. I won't say they didn't feel comfortable. I would say that going into my community, they didn't feel comfortable enough to articulate a conversation, which was quite strange to me, because these are
the experts.
Exactly.
Yeah.
So we need to also do some work in some training as well. And we have material that is training them how to talk to the community. But you get people that don't feel comfortable, but I also say to them, you have to think about your impact in the world. And how do you see the world different? How do you really want to make better health outcomes? It's about being, doing your rigorous science, but it's also about touching the patient.
I love that. That is exactly it. Well, hopefully your colleagues will come on board with that. Rodney, let's pick up on that. From your perspective, is that where you see that the narrative needs to shift, that people need to come from behind the research and come step into the community and bring it actually there to the community? What would you say about disrupting the narrative, rewriting the narrative?
Yeah, no, I think that's an important aspect. I tend to think a lot about, one, there's a conversation that exists today around awareness gaps in the Black community. There's a conversation that exists around sort of changes in behavior. And I think we all know there's a conversation that exists around trust. And so if you want to take that maybe a little deeper, one level below, you would actually say part of it is because people tend to think in the Black community that cancer care is hard. It's hard, right? It's hard to navigate. It's hard to get access. It's hard to, they tend to think of it being really expensive, right? So it's hard because maybe we don't have the resources to get the best quality care. And the only way you get the best quality care, the narrative is that we need to disrupt, is in the big, large academic medical centers and the cancer centers that are around the country. And we need to change that narrative, right? Because in reality, what we want to do is start to bring more awareness locally, as Carrie talked about, into the community. And we need to make sure people understand it's not hard. But one of the things that I probably spend a lot of time on is saying we can't put all the onus on the Black community. The system needs to step up, right? The system needs to change. The system,
Talk about that, yeah.
Yeah, the system needs to find a way to make sure that the Black community is getting diagnosed earlier, so early detection, because we all know, Carrie talked about it, right? The earlier you're diagnosed with cancer, the better the outcomes. That's a fact, right? There's data that supports that. Early diagnosis, early detection, better outcomes. And unfortunately, today we're getting diagnosed later, and that's part of the challenge. But if we put the onus on the system to start to bring these solutions into the local community a little bit earlier and more consistently as well across the board, I think what narrative we will change is the narrative that says cancer care is hard, cancer care is difficult to navigate, cancer care is inaccessible, and we will start to change that to one that says, I can actually get the best cancer care here locally in the community because these are the people that I trust and I work with.
Yeah. I just want to say one more thing is that for us in the field of community engagement, we have to stop thinking of all of these special initiatives. Our storytelling this is standard care. And I think sometimes that we as clinicians or people in the field, we make all of these initiatives without, and some people don't understand, this is standard care. This is the care that our communities deserve. So I just want to mention that.
No, absolutely. So what we're talking about is really standardizing the care, taking it from the field that you have to be in a major metropolitan area next to a major cancer resource center, and that you are able to get access to the treatment you need in your local community.
Yeah, and because I would just add, I mean, look at Novartis, we talk about bringing innovation, right? And we talk about innovation through science. And I'd like to say, so what if you have innovation, but you can't get it to the people, right? So we have to bring that innovation, that science, that new therapy that's out there to the local community to make sure everybody has access to it as well.
Excellent. Now you bring me to another point, access to clinical trials, and clinical trials in general being one of the biggest gaps in equity. What will it take to move the needle? I know on BlackDoctor, we've got clinical trial resources. We reach out to partners to elevate and amplify clinical trials, but how are we getting them to the people to be included in them? How are we getting the doctors that are in caring about our community to actually take part and be a part of those clinical trials? What needs to happen with clinical trials? I'm going to look at you first, Carrie, and see what you have to say.
So one thing that we're doing at the American Cancer Society is we took a step back to look at infrastructure within some of the clinical community clinics to see what do actually they need. First of all, what support do they need as far as like what equipment and all the other things? Even do they need more patient navigators? So that's the first thing that we did. And we work with Trial Library also, and then the Prostate Cancer Consortium as well. We work with them.
So this was both breast cancer and prostate cancer.
This was specifically prostate cancer. So, but I think the system, again, is so broken. Again, it goes back to that accountability. First, we needed, I feel like personally, we need to actually be in the clinics, be a part of the trial myself. I currently go through a trial with biomarker testing, so I'm able to share that, my experience, because I didn't know about clinical trials prior to working with the American Cancer Society. And not that I was afraid of it, but I didn't have the education to know.
And is that one of the gaps right there that our community doesn't know? We don't know, we're not a part of it because it sounds like, almost to Rodney's point about cancer care in general, it sounds big, it sounds scary. We don't know how to approach it. So is that one of the big gaps, is the awareness of clinical trials, what's involved in it, how to become a part of one? Rodney, would you say that?
Absolutely. And there's a lot of ands to that.
There is.
A lot of ands. And we have to take away that narrative of complexity and again, make it just simplify it for everybody. Like clinical trials is for everyone, right? There's a narrative that people think clinical trials is specialized. It only goes to certain people. That some of the narrative is just like, it's for everybody. I also think that, again, you're gonna hear me say this over and over. I think the onus is also, again, on the system, by the way. Mm-hmm. And by the way, a lot of us are a part of the system, so we can make changes. The system needs to, like, I think about the criteria that's required to, or actually I like to use the exclusion criteria.
Interesting, speak on that.
Yeah, for clinical trials, because sometimes what happens with the exclusion criteria is you take people, a community completely out of the trial. even if they're aware of it, even if they have the disease. So let's just say they say one of the exclusion criteria is high blood pressure. We're not taking anybody with high blood pressure. And then you're coming into community maybe with high blood pressure or diabetes or something like that, and they are completely excluded from the clinical trial. So I think we have to do a better job of finding ways to include people with underlying diseases and not exclude those people, so we can at least start to make them aware and also start to bring them in at the ground level in that space as well. So I think exclusion criteria, and Carrie, you can probably talk more specifically to that, but it's a really important point.
No, that's an amazing point right there, because you think about it, if that is the exclusion criteria and you have so many people in the Black community that have high blood pressure or diabetes, they're still going to need the drugs and the research and the information, but if they're never part of the clinical trials and excluded. So that's an amazing point.
And if they're never been told by their doctor or clinician that's an available point as a next step.
How often are doctors sharing that with the patients? Is that one of the areas we could close the gap to? If you're going to your doctor, how much of a practice is it for the physicians to be speaking to their patients and saying, you know, you could look into a clinical trial. You might be eligible for a clinical trial. Is that a discussion that's happening in the doctor's office?
I think it depends. I'm actually going to give a real world example because it literally just happened to me on last Friday. Okay. So part of it goes back to what I was talking about, is bringing it to a local level. So I had a local physician, BlackDoctor, who was doing a prostate cancer clinical trial. And that's part of it, right? We need it local. So he's very focused on making sure I bring people of color into these trials.
Okay.
And this was specifically to Novartis. What he said to me was he has so many eligible patients, he needs more slots, right? And so where can I help him get more slots? And the more slots is all about getting more patients into these clinical trials, because he had more patients sign up fast. And that's not my space per se, but at least I could reach out to the people within Novartis and say, hey, we have a motivated, person that wants to enroll more patients at a faster time. And all I did was just facilitate a conversation, right? Put him into that person in touch. He was just trying to move through the system fast because he could have done it himself, but he know how slow our system moves. And he sent me a note on Monday and said, hey, I got a few more slots. Thank you. And it wasn't really me specifically. It was just me facilitating and him reaching out first.
Yeah.
And me facilitating. But again, it's because he's in a community. He wasn't at a big academic medical center. And I think that's, we need to get these trials into these local communities as well, because guess what? We have doctors that patients trust.
Yes.
Right.
Again, going back to the trust factor that you mentioned. It's all about the trust.
They trust them. And if they tell them that there's this clinical trial on prostate cancer, on breast cancer, or whatever it may be, they're more likely to enroll as well.
Thank you. And I think the other point that you brought up within that is he was motivated. We know so many physicians are limited by the time that they have to spend with the patient when they're meeting with them. They have to be motivated to be part of that clinical trial, to make that extra phone call. But you see what happened when you close that loop for that. Carrie, can you speak on that? Like, how do we get the community level, not just the big level doctors, to really tap in, be interested, and reach out when they're looking to fill those slots and things? I mean, this sounds like the whole way that we need to approach making the changes in the system. As you pointed out, Rodney, we're all part of that system. Is it just each one teach one, as they say, and reaching out to the next person and bringing them in?
I think we have to go a higher level of just coming from, AACR. Many of you may have been there. All the researchers across the country. ASCO is coming up. Again, me personally, I am advocating at the highest level that, again, we gather in these large meetings.
Yeah.
We also have to bring those leaders. So going to like the NCI directors, going to, working with Ricky and Dr. Rob Wynn to help us advocate and champion these type topics and being in the community at the highest level. So that's the only way that I think that we can actually make change, is that we start going to the NCI directors, our leaders. I mean, we certainly at the American Cancer Society, our new CEO, Shane Jacobson, I'm always advocating and sending messages to both he and Dr. Bill Dayhut. So I think that's the only way. And again, none of this happens in isolation, and we know that. That's why we are all gathered here today. But it's going to take the collective of our organizations to continue to amplify that and make it a call of action that the community needs to be first.
I love that. And we're in our last moments and we're wrapping up. Rodney, I'm going to ask you, what is the one immediate change that we could put into place? Is it policy, practice, community? Walking out of this room today, is there something that this collective can do, or is it taking it back to somebody in their organization? What's the one thing that we could do?
Actually, I'm going to make it really simple. One action that I think we all can take is we have to reach out within our own sort of circles and start to have conversations. And I can't remember who said it last night. Someone was talking about at the reception about their circle of top 5 people that they're around, et cetera. So you got these top 5 people you're around. Make sure you're having conversations. A quick example, I'm literally at a New York Knicks game with one of my buddies, my wife, his wife. And I took that moment because I knew his wife was listening to say, have you gotten your PSA? And he was like, what? What's a PSA? It's like, so we end up having that. And then now his wife is in on that conversation. I could have had that conversation.
That was tricky. I see what you did there.
It was just because I need to put a little bit more pressure on my friends to make sure that they're doing at least the basics, right? And so I think that's an action all of us can do, is have those conversations. For the men in here, ask your friends, have you had your, PSA is now for Black men at 45 and above, right? Like, have you had your PSA? And it's as simple as a blood test. That's all it is, as simple as a blood test. And another example, one of my buddies,
which not everyone knows.
Not as everyone knows.
Is a couple of things that stop people in their tracks on that, and they don't realize that.
Exactly. It's simple as a blood test. And this literally happened this weekend. One of my buddies just hit me with PSA, That's all he hit in his text to me. And that's the conversation I'm having with my friends. Like, now they're getting their PSA test and they're sending me their numbers. I don't want their numbers, but at least I know.
Thank you for TMI.
But they know what they're doing, what needs to be done. And so the action, if you didn't hear me, for men and for the women in here, make sure the men are getting their PSA every year, not like once every 5 years, every single year.
Your husband, your brother, your nephew, your son, whoever.
Yes, right.
Yes, and
uncle.
One thing I want to mention as well is, please, let's start talking to our children and our young people about screening and early detection. As many of you have heard, colorectal cancer is on the rise in younger adults, and that's our next generation. So.
Absolutely. Thank you all very much. I'm going to actually see if we could take a couple questions from the audience. If we've got any, I've got a mic here. There you go.
Good morning. Good morning.
Morning.
Thank you very much for the information that you have provided. I actually took a quote from Miss Carrie Goldberg. I hope I said that correctly. I have been a healthcare advocate and provider and therapist and cook for my mom, who has been navigating with a lot of health issues. And there's a lot of notion or taboo about medical trials. And it was so powerful when you said to be part of the trials. When you hear that from your medical professionals and say, this is my story, it becomes real, personal, and it's not, this is arm's length happening to you. You should be doing this. I don't have to do this. So there's sort of a wall that comes with medical professionals. And in this experience of probably 14 years of navigating with my mom, I have seen, especially in the when we have Black doctors, that there's more of that personal approach in the conversations. So I want to congratulate you and say thank you for sharing that, because then the conversation becomes, I am part of the community. I'm in this journey with you, and I'm doing this because I truly care beyond this is my career. I'm in this path with you as well. So I don't have a question. I just really wanted to point that out. Thank you.
Hi, my name is Clese Erickson, and I do a lot of health workforce research studies, including on clinical research coordinators. And I wondered if you have thought about or work with the society that represents them, because they're very focused on diversifying that profession and creating career ladders as an avenue for addressing some of the trust and building connections with the community. I wonder if that's something that you all are thinking about.
I would actually say not specifically with that organization. Novartis doesn't work with them, but happy to chat more about it. But one thing I would say is so I agree with your comment in terms of working with community sort of navigators who talk to patients. So we just kicked off a new initiative, our Integrated Health Accelerators, the IHAs, in 5 cities across the US. And they're exactly that. They're going into the places like New York and Detroit, Houston, et cetera, into those communities, working with local advocacy groups where, again, goes back to the trust, because that's where the trust happens, and you can have those conversations at a local level and allows for them to really open up and engage in very real discussion around specifically cancer as well. So I think it's a great place that we can go, and hopefully we'll get some data that comes out of that. And we start to see, at the end of the day, what we're trying to do is improve outcomes. And the thing that I always say is your zip code should not determine how long you live, period.
Good morning. I have a question, and I'll give you the reason why I ask it second. My question is, do you know of studies or any data that helps us understand why we as people of color enroll our children with cancer in terms of clinical trials at a much higher rate than the adults do for themselves? What is it about that we don't understand? And I have my own theories. I'm a pediatric hemonc by training. So I'm just curious if you know of any data that kind of gives us a collective view versus just an anecdotal view that I have.
Yes, I haven't studied any particular data around that. I would absolutely love the opportunity to follow up with you on that question, though, with some of our team, because I haven't specifically studied that. I have some theories, but I want to look at the data first before I respond. So.
I was going to say, I would love to hear your theory.
Yes, I mean, share your theory. It may be similar to my theory as well, but.
Well, I can give you 2 theories. One theory is that I know that just being a pediatric physician, that you're going to have to talk to patients, meeting their parents. And so that's I think there's a lot more emphasis on communication and dialogue, because you have to get consent for the treatment, no matter whether it's pneumonia treatment, whether it's, sickle cell treatment, whether it's cancer treatment. And so I think that's probably one factor that, you're kind of ingrained. And also many of the places where children are treated for cancer, the teams are quite strong in terms of all the ancillary services and personnel that you need to kind of keep reinforcing and supporting that family to bring their child back again and again and again. We have great, clinical resource or research nurses and social workers and child therapists, all the things you can imagine. It's, and I'm thinking about the atmosphere in a children's hospital in particular, because most children do get treated at tertiary care centers in this country. Most do. So that's the other conundrum there, because they come into the big medical centers because their physicians refer them. And then I think we have maybe just done a little bit more work around that in terms of just supporting a family. And that may help them be able to feel comfortable over time. And even the language barriers, lots of translators, interpreters for all the languages you can imagine. And that's also another barrier that's kind of overcome.
I think you're spot on right there. I really do. And also, we also do a lot for our children and then overlook some of the things in terms of taking care of our own health. Thank you so much, everybody. Thank you, Rodney and Carrie, for being on the panel. All right, thank you. We're gonna do a group shot.
Can we give another round of applause to our panelists? Powerful, powerful panel. What'd you think, Derek?
I thought it was incredible. I'd like to welcome everybody once again to the 2026 Top Blacks in Healthcare Thought Leadership Summit. This is the Life Stage, LIF, the Limitless Impact Foundation stage. They sponsored the stage this year, so we want to thank and give a huge shout out to our sponsor. Jade, I'm going off script again.
All right.
on this time. I just want to see show of hands as far as gatherings like this year in 2026. Let's say if you've been to gatherings like this maybe 5 times so far this year, raise your hand. 5 times? Less? Okay. Now, when I was talking to somebody outside, they were saying how we always gather together. We always talk about what needs to be done. This year, I wanted to make sure that we highlighted some of the things that were talked about on this panel and all the panels today, because they used the word specifically in that panel that I want to call out. I believe Rodney Gillespie, he said some actionable steps. So today, everybody's going to leave with some actionable steps that we can take and we can use in order to truly change our community. There was one thing that I want to bring about that was said. The system needs to be changed, he said, but we can make that change. Many of us are part of that system that was said. So what we can do, an actionable step, everybody say actionable.
Actionable.
Everybody say actionable.
Actionable.
Y'all sound good. We could take this on the road. All right. One actionable step we can take is facilitate the conversations. So just like Rodney spoke about earlier, we need to facilitate those conversations in order to connect people and then start making the change, start moving the needle, start changing the numbers within our community. So that was one of the things that stood out for me.
Yeah, you know what stood out to me was when he said that people think cancer care is hard. And I get that. I've heard that. I would think that. But I think it's people like us in the room, those who are in health media, those who are at pharmaceutical companies, those who are healthcare professionals, who can raise that awareness and create a difference. So as you said, those actionable steps, it's up to us to kind of create that change and make sure that our community can see that difference in cancer care and feel as though it is accessible. Not even feel, but actually see that it is accessible.
That's good. That's good. And I can't remember the young lady that was speaking over here talking about her mom. That just reminded me, these are real stories, talking about real people. You know, when we talk about cancer care, both my father and my uncle both had prostate cancer. They went through the process. Thank God that they're still here. But that's real life, real situations that we had to face as a family, as a community. And I'm so glad to see the faces and the people represented here that have helped make some of those families and those conversations a little bit easier, a little better for us all. So continuing on with our next panel, who do we have?
We have heart work. So we'll be addressing the silent crisis within our community.
So let's please welcome the next panel. Come on up.
right, thank you. Thank you, everybody. So we're actually going to take a small break before we move to the panel. So everyone who came in, if you want to grab something real quick, refresh your coffee, warm it up, grab a quick bite if you came in later, and then we're going to set up for the next panel. All right, thank you. Just a quick 7 minutes.
Interested in the dental panel. Is there a reason?
One, two, 1, 2, 1, 2.
Two. So for the heart health panelists, that would be Dr. Jane Morgan, Dr. Keith Ferdinand, and Dr. Tony Lozama. Can you come to the front of the room? Thank you. Dr. Keith Ferdinand. Yes. Yes. 5 minutes. Okay. 10:30. Okay. Check. 1, 2, 1, 2. 5 minutes. 5 minutes. So I'm following 10:30. Make it longer. Okay. Yep. Yep. Yeah. Okay. And she's a timekeeper. Ira is a timekeeper. Yeah. Getting them right now. Okay.
She's the moderator.
No, Christian is. fix you. Yeah, it was just one. Okay, everybody.
Everyone had a chance to grab a break. All right, we're gonna get ready for the next panel. Okay, if everyone can take their seats, we're gonna get ready and start the next panel. Okay. Yeah. Hi, everybody. If you could take your seats and come back from the break, we're about to start our next panel. Heart work addressing the silent crisis in our community. All right, we'll do 1 minute for everyone to get back. There we go. All right, we're just waiting for one of our panelists to come back. So thank you. So I know that we started with breast cancer and prostate cancer and rewriting the narrative. We started heavy, but we've got a lot of work to do. So it's important for us to keep diving in, sharing our narratives and sharing our experience, and most importantly, coming up with a blueprint for how we can move forward. All right, thank you. I'm going to welcome the panelists and welcome you all. My name again is Kristen Vaughn. I am the Chief Content Officer for BlackDoctor. I'm going to be moderating another important conversation, the one on cardiovascular health. Heart disease remains the leading cause of death in this country, but in Black communities, it's often a silent crisis caused by, it's often a silent crisis shaped by access, awareness, and missed opportunities for early detection. And unfortunately, that's a theme that's going to go across all of our panels today is early detection, awareness, and screening. So that's important to remember. But while we're seeing promising efforts from tackling cardiology deserts, thanks to the Association of Black Cardiologists, and for advancing new screenings and therapies. But the most important question is, are these innovations reaching the people who need them most? Again, another theme that we're going to see throughout today's summit. Today's conversation is about closing that gap. It's about bringing what's possible in cardiovascular care and tying it to what's actually happening in our communities. All right, let's get into it. I'm going to welcome my panelists. So I'm going to welcome Dr. Ferdinand. Come on up, and we're going to come up here and get a chance to meet up with you. All right. Dr. Jane Morgan, and Dr. Tony Lazama. There you go. All right. Thank you. I'm going to move you guys just a little bit. Oh, Bernard, I'm going to. You're like, I knew that was going to happen as soon as I sat down. There you go. All right, welcome, welcome. So again, today's panel is about cardiovascular health. So again, I want to thank my panelists. One more round of applause for them. All right, and I'm going to start and let everybody share a little bit about their background, who they are, what they're bringing to the conversation, which is going to be a lively one. Dr. Jane Morgan, if you could start off for us.
Sure. My name is Dr. Jane Morgan. I'm a cardiologist and women's health and menopause expert, and have really gravitated into that area in the last few years. My background really is in research. I was at Piedmont Healthcare, the largest healthcare system in Georgia, for 9 years, leading their cardiovascular research program. But now I'm the vice president of medical affairs for Hello Heart, which is a digital AI company moving forward in the women's health space. We actually have just been named the fastest growing company in Silicon Valley. So that's where we are today.
Yes. Amazing. Thank you. Dr. Tony Lazama, tell us a little bit about your background.
Thank you. And thank you, BDO, for allowing me to be here on stage with these luminaries. Congratulations. That's awesome news about the company. So my name is Tony Lazama. I am one of the U.S. medical directors in cardiovascular disease at Novartis Pharmaceuticals. And so I am really focused on, obviously, cardiovascular disease, but really driving awareness around the issue of cardiovascular disease, and particularly with the African-American community, but just as a whole. I'm really, really focused on elevated LP(a). That's my daily bread and butter, but I'm also involved with cholesterol and blood pressure as well. And at the company, I lead a lot of our initiatives when it comes to testing and being out within this community and raising awareness, but also a lot of our implementation science work and a lot of our partnerships with sports, including the NBA and the NFL. And additionally, really driving the ball forward, no pun intended, with the sports on a lot of the AI work that we've been doing. And so I actually am fortunate enough to lead a couple of different AI initiatives where we're trying to leverage that technology to help providers and patients alike.
We're going to come back and talk a little bit more about that. AI is on the lips of everybody, so we always want to know what's going on there. Dr. Keith Ferdinand, if you could tell us.
I'm Dr. Keith Ferdinand. I'm a professor of medicine at Tulane University in New Orleans, Louisiana, my hometown. I'm from New Orleans. And the endowed chair in preventive cardiology at Tulane. I'm also chief science officer of the Association of Black Cardiologists. I've practiced medicine for many decades, both as a clinician. I also do research and a lot of community intervention. We have a large NIH grant. We go into the churches in New Orleans and control blood pressure, lipids, and glucose in a community setting. My whole career has been dedicated, especially to the Black community. I'm a child of the lower Ninth Ward. And if you look at the #1 cause of death of the white-Black mortality gap, cancer, of course, is very important, but it's overwhelmingly cardiovascular disease. So that's where I put my focus.
That's a lot. You've got a lot on your shoulders. All of you are actually taking on such important work in the community. And we're proud to have you guys on the stage today because the accomplishments that you guys have brought already are so meaningful. There's a lot of work to do. Let's get into it. So one thing I want to talk about is if we're serious about changing the outcomes in the Black community, and obviously we are, in the next 5 to 10 years, what would you say is the one shift that needs to happen when we're looking at clinical, community-based, whether it's policy-driven? What would have the greatest impact on reducing heart disease in Black communities?
I think the #1 cause of poor outcomes is not having insurance. They have actually done studies and they look at uninsured versus insured. People who don't have insurance can't get care. They get care late. They use the emergency department as their primary source. So when you go to the doctor, when you can't urinate, so you already have end-stage renal disease, you're on dialysis. When you can't breathe, you have heart failure, the heart's already given out. When you have chest pain, I call it the Fred Sanford syndrome. You've already had a heart attack. And many of those things are preventable if the person will get early care. Now we know even persons who have insurance, the insurance is often limited. in its scope. I used to work in a restaurant called Ross and Us that still has a hotel on Bourbon Street, and it was minimum wage and all you could steal. You didn't have insurance. You had a gig, but when Essence would leave and the Super Bowl would leave and Jazz Fest would leave, Bill, we don't need you next week. So those are really big drivers, the social drivers of health. Not only the built environment where you live, but not having access to care.
Access to care, having the access to the insurance.
And I'll just add to the conversation. I think when we're talking about digital health, it is my projection as we look forward that this may be an opportunity to really close the gap in healthcare, to put healthcare in the hands of people who already are utilizing their phones, who are already utilizing wearables, to begin to connect the dots such that people understand how their behaviors during the day actually are contributing to risk factors that may end up with an emergency room visit 6 months later. So how can we intervene today? What alerts can we give you? How can you track your blood pressure? How can you track your cholesterol? How can we track your heart rate? But then give you those insights where you can start to connect the dots and say, aha, I see here X led to Y, and if I don't intervene now, I'll end up Z in the emergency room. And so, I think as we move forward, we will see increasingly the general public being empowered with digital access to make good decisions. And my hope is that in communities like our community, the Black community, that this will allow us to begin to close the gap in access to healthcare, give you information such that you can make decisions as best as you can in real time and can make behavioral changes, because we know that 80% of cardiovascular disease is behaviorally driven. These are our choices. And sometimes, as Dr. Ferdinand says, these are not our choices. It's where we live, where we work, the foods that we're eating. Some people have more choices and decision-making over that than others, but all of this contributes to heart disease. There's only about 15% or so, or 20, that is not related to sort of our overall lifestyles. And so that's where I would like to see sort of it going, where we're putting it in the hands of people to be able to make decisions, preventative decisions, to improve their lives.
And tying in with digital health, like you said, that's great because our community is disproportionately using our phones and things. So you've got to get the health apps on the phone and not just be looking at whatever else might be on the phone, using it for good, using it for your health while you've got it in your hand. That's perfect. Dr. Lozama?
So I agree with both comments. I think bridging the gap between the ivory towers and the community itself. And so digital can be a huge part of that. So if we're already on our phones, let's try to tap into this to not just bring an app, but usable information through partnerships, whether it be with ABC or BDO or whomever, that you can have digestible materials that are at the cultural relevancy level that will pick up and resonate with folks. And then at the same time, it's a pincer movement. Those community centers that are not the big academic medical centers, making sure people there know what they need to know and that they're empowered. And so we have ample evidence showing that if you can actually educate and find champions within those community health centers, those fairly qualified health centers, you can actually make a big shift in terms of outcomes, whether it be screening, testing, just overall health benefit. And so I think bringing it all together to where we address the social determinants of health issues by empowering the community centers where these people potentially could go and they're closer, as opposed to a big academic center where they may be a little bit intimidated to go to, but then also leveraging those digital tools so that when they do show up, whether it be at Georgetown Health or Delaware Valley Gap Health Center, they will have the knowledge that they have and that they need to have in order to better represent themselves and advocate for themselves when it comes to their health.
And it drives more meaningful conversations with the physician, because you come with your data that the physician can now review and see what's really happening to you out in the real world. And I think sometimes what we don't have are meaningful conversations with the doctor who comes in, they have a short period of time, you're flustered, you're intimidated, And you sometimes, especially for women, we leave with more questions than we came in with.
Yeah.
And nobody really addresses it.
You bring me to my next question, which is hearing about that heart attacks present differently in women. And as you're saying, we leave our doctor's office with more questions as women. When we're out there dealing with heart attacks at a level where we often have the idea that heart attacks and women don't come together, when we think about heart attacks with women, and now we know as a result that things are not negatively impacting women, what are the warning signs for women? How can we change that narrative? Because again, I think the idea is heart attacks, we don't think about women. So when women are quick and on the move, what are we missing that we're thinking this is just part of what we normally do in our running around? What are the warning signs that women are missing?
Yeah, the biggest warning sign is just being a woman. And I will tell you why that's the biggest warning sign. It's the biggest warning sign.
I agree.
Because it's a blind spot in the health system.
It is.
We are not seen. And so the biggest risk factor is just having 2 X chromosomes in the United States of America, because there's a blind spot in the health system. Now, if I want to talk about specific medical transitions in a woman's life, there are specific times when our risk of heart disease increases where we are also ignored. And so one of those would be pregnancy complications. You hear about hypertension, gestational diabetes, and even below birth weight babies, preeclampsia, those kinds of things. Those are all risk factors for heart disease. That woman has a 2-fold increased risk of heart disease in her lifespan. And we really don't have the integration of cardiologists in the care of that patient. So let me give you an example why diversity is important. It's not just when we talk about diversity, we talk about in medicine coming out of our silos. All of the doctors talking. And I trained in cardiology right here at George Washington University. This is where I did my internal medicine residency, by the way. I'm back home. I live down at 2000 F Street, if you guys want to see where I live. Now it's totally unaffordable, but back then these were the cheap seats, right? And this is where I lived, right down the street from the hospital, in a studio apartment. I had a beautiful view of the brick wall of the next building because that's what I could afford. Now, even that apartment is unaffordable. But when we talk about what happens in healthcare to women, an OBGYN sees a patient, really manages these patients with pregnancy complications. And an OBGYN is trained and will say, this is a 38-year-old woman in her 32nd week of pregnancy with preeclampsia. A cardiologist comes in to see that same patient and says, this is a 38-year-old woman in a volume overloaded state who has just failed her stress test. Same patient. We're going to be driven in different outcomes. But that cardiologist is not a part of that conversation. And right here where I trained at George Washington University, I don't even know where the OBGYNs were in the hospital. We called them, they had their own ER entrance. They were like we called it the happy side of the hospital. They're over in the happy side. The rest of us were, in grunge work, and they were delivering babies. And, so when I say there's no interaction, I literally, to this day, still don't know where the maternity ER entrance is to the hospital where I literally trained. That's how siloed it was. We never went over there.
And so the records and
That's right.
Pulling together.
Not only the records, we
patient.
didn't have the conversations. If we were friends, we see each other in the cafeteria. So that's the kind of thing where these silos have to break down. The next stage is in menopause, where your risk of heart disease also increases. And that's also completely ignored. And so this is why I say being a woman is the risk factor.
And Dr. Ferdinand, could you build on that as well?
Which part?
Does it start with being a woman?
Well, actually, if you look at heart disease,
Yes.
age is a powerful predictor of risk. When we get older, our risk accelerates. When a woman goes through menopause, 5 to 6 years later, average menopause is 51.3 years. So after that time, there's an acceleration in blood pressure, lipids, and risk. There are more older women than older men. So there are actually more people with heart disease who are women than men in the United States. And in terms of the identification of a heart attack, yes, it may manifest itself in very strange ways. You may not get the crushing chest pain into the left arm that a man may have. Some women will just feel fatigue or indigestion or tired. And if the clinician is not taking that woman's symptoms seriously, then he'll tell her, you know, you're nervous or you're working too much or you need to get more rest without really investigating what's going on. And that is a real problem. It is a blind spot. I agree with that.
So, as a Black woman going to the doctor, how do I get them to take me seriously? How, when I say, what did you say, indigestion and fatigue and all of the things that maybe go into a busy lifestyle, family, all of the responsibilities?
Tony can talk about this somewhat. You have to know your risk factors. There are things that we measure: the conventional blood pressure, the glucose, the cholesterol. The new one is lipoprotein little a. It's a genetic factor, and it's an equal opportunity factor. It's more common in people of sub-Saharan and sub-Saharan African and South Asian descent, but it also manifests itself as heart disease, especially in women and earlier in life. And I have had patients who have very high LPAs, and Dr. Morgan knows about this, and nobody told them. And they went on to have an event. And hopefully in the future we can address that. One thing I did want to say is that although my colleagues talk very eloquently about AI and information tools and et cetera, I'm concerned with misinformation, junk. I'm going to say something that's provocative, but you do your own research, as they say, and you'll find out it's true. A lot of what's on the internet is not based on science. It's based on someone who has an agenda. It's often an individual who has a product to sell or wants you to join their club. And in the worst case scenario, this is what's really provocative. It's international marauders, especially from Russia, who not only inject themselves in our politics, but inject themselves in our medicine and purposely will send misinformation. So as you get those tools out, Tony and Jane, make sure that they're valid. The information is valid, because there are going to be a lot of people going to send information to be disseminated to the population that is actually harmful.
Got it. Dr. Tony Lozama, please hop in. And
You said a lot of very, very factual things. And I think with AI, it's very important to note garbage in, garbage out, as my mentor used to say. So we are taking some steps to make sure that we don't have garbage going in. And so when we think about AI and these large language models, you have to make sure that it's not filled with filth. Because if you get that filth going in, you're going to get filth coming out, whether it be Russian filth or Chinese filth, or, you know, filth is filth. I really
what are the guardrails? What are the steps that you guys are taking to keep it pure?
So I think that's a great question, outstanding question. On our end, with the projects that I'm working on, it's to make sure that we're keeping the data clean and there's lots of quality control checks. And so we're not allowing just inherent bias to come in. And so if we're trying to build a data set, for example, to find patients that are at higher risk, we're not going to build a data set on only white men. Because if it's only white men, then it won't recognize Black women, it won't recognize South Asian men. So things like that, understanding it before you go in will be very important. We talked about female risk, and, you know, like a lot of times you're brushed off, you're tired. I was raised by Black women, they're always tired. And they're always tired because they had to raise me. So with that being said, I think it's really important that information gets out there. So I was having this conversation actually with Jade just a little bit ago. This is not Novartis data. This is data from the American Heart Association. And they showed that Black women over the age of 20, 60% of them have some form of cardiovascular disease. So if you're in a situation to where you're actually seeing a Black woman and she's talking about symptoms that could sort of be a heart attack, but it's not straight away, just understand and recognize that, hey, you know, she probably is part of that 60% group. There's a 3 or 5 chance that she's in that 60%. Dr. Ferdinand mentioned elevated Lp(a). This is an emerging risk factor that's not your fault. It's genetic. So it's not because you ate wrong or you didn't exercise. You're just born this way. And if you're a Black person, you're more likely to have it. 1 in 5 people have it. But if you're Black, it's more like 1 in 4. We have data that shows that it's much more. But
Do
what
you have
Black-
to ask to be screened for it, or
That's a
what
great
kind of
question.
genetic testing?
I was just going to get to that. And so, we're here.
Right, we're here.
So it's a simple blood test. So much like what Rodney was saying, where it's just like it's a simple blood test. This is not a cheek swab. Nobody's going to put your DNA in the database. It's a simple blood test. You do it one time, and you'll know if you're high, then you're high. This is genetic. If you're low, then you're low. Like, it's one time. And it's really, really straightforward. And you have to ask for it, though. Now, recently, the AHA and the ACC, so the governing bodies, have come out with new guidelines recommending that all adults are checked at least once in their lifetime. So that's real great progress, because it hasn't really happened before. But I do think if we're going to be talking about women's health, African-American women's health, it would be important to consider elevated LP(a) as well, because all of the data shows that we have that Black women, not only are they more likely to have it, they have the highest levels compared to anybody. And
Wow.
that was shown in some of the work that Dr. Morgan was a part of, that Dr. Ferdinand was part of, that I was a part of, and others as well.
And I'll just add to that, because I'm on the steering committee of this LP(a) at Novartis. So I just want to add one little perspective from a women's health. Estrogen has been shown to cause some regression of LP(a) of 10% of it that's not genetic. So something to just consider as we go through perimenopause and menopause, and you think about hormone replacement therapy and the effects of estrogen on the body. It looks, we're looking at the data, it looks as if estrogen also may have some impact on a small portion of that LP(a). So more to come as we sort of dig deeper into women's health and heart disease.
That's amazing. Thank you guys on the panel. Thank you so much for giving us such new perspectives, putting additional screenings on our plate, giving us more information to be armed for our next appointments with our physicians, asking for some of the testing. So thank you. We're going to take a couple quick questions from the audience. I see one over here. Oh, and I cannot not acknowledge our CEO of BlackDoctor. Please stand.
Good morning, everyone. And I really, really, really appreciate this panel. We asked about the main risk factors for poor access to care for cardiovascular disease. And you talked about insurance, you talked about access. And, for somebody who's insured, who's a physician, who has great access, I think what we're missing is the inherent bias of the healthcare system when it comes to treating women, Black women, even educated Black women. When you go to the emergency room, they brush off your symptoms. And if you don't fight and ask, you're not going to get what you need. And so I do want to call out that we need to figure out a way to help our communities be more health literate, so they have the language to advocate for themselves when they go to the emergency room. If my mom goes alone, she doesn't get the same kind of care than if I go with her. And I can't go with her all the time. And it happens over and over and over again. So how do we pass this information to the general population, so they have trusted information that is legible, thing that they can understand, visual, and then take with them to advocate for their cardiovascular health? I think that's a missing link in this conversation.
Send them to BlackDoctor.com. we have a lot of the resources and information that you're talking about there in terms of bringing people up to speed on the most recent screenings, awareness, detection, things that they need to know. But in addition to that, I'm going to throw that to Dr. Ferdinand.
No, I don't disagree with that at all. There's clear bias in the system, and how people are treated by the clinicians is a big part of it. The mistreatment, the unawareness of differences. Even when you take digital things like the watch that people wear, it may not pick up the color. Your skin may have a different interpretation, whether you have blood pressure and your heart rate. Even the oximeter that was used during the COVID pandemic, the numbers would be often falsely low because it couldn't detect oxygen. Bias is all over. I mean, racism, the structure of how America was built, is integral to the problems we have today, no doubt. But if you look at being uninsured and underinsured as a mortality marker, it is very, very, very powerful. And if we don't address that, For the individual, they need to have those tools where they can address their physician. I agree, information, AI, etc. But if we don't have people who have insurance, they're not even gonna be able to get to that physician. You can't stuff enough dollars in your mattress to get medical care in the United States right now.
Hello? Okay, so it's a great point. And I think it's going to take a team approach to address this. So education is obviously going to be huge. But I think the industry itself and the healthcare system itself needs to take a look in the mirror, frankly. And so I cannot take credit for this quote. There's a person that I respect greatly, Filoso Fakarede. He actually stated this quote, that the system is getting the outcomes that it was designed to get.
Right.
And so when you take a step back and listen to this, that's very, very powerful. And so you have to sit there and think, well, how do you address that? And I think it starts internally. And so right up the street, the American College of Cardiology, in their premier journal, JACC, a couple of years back, so Dr. Melvin Eccles was involved with this, Harlan Krumholtz was involved with this. They put out I don't know how else to say it, but just such an explosive publication to Black people, to the world, saying that in the last 20 years, from 1999 to 2020, 780,000 excess deaths in the Black community were attributed to cardiovascular disease. So just take a second and close your eyes and picture San Francisco, and then picture every single street in San Francisco empty. That represents how many Black lives were lost because of cardiovascular disease in just the last 20 years. So, and that's all they looked at, 20 years. So what happens if you go back to 1950, 1960? Who knows? So with that being said, I think it's very important to have everyone acknowledge, okay, here's the data. This is the problem that we have. But now let's be action-oriented. Let's take some action items and see what we can do to address this. So insurance is a huge piece, but actually having AI or intelligence in general and health literacy is a huge piece as well. And so if we don't all of us recognize the problems, including the systems themselves, then it's going to be really, really hard for us to move forward. So I think just having the information at the core of everything, what's going wrong, what do you need to address it, how do you advocate for yourself, is going to be critical. So that's where that partnership comes in, whether it be with BlackDoctor or ABC or ACC or the variety of patient advocacy groups. It's going to be really important that we all work together to address these issues.
And I can say this in 10 seconds. Even when you have insurance, because of high copays, especially with newer medicines and therapeutics and surgery, people can't afford them. So they jockey around whether or not they're going to get a test or take a medicine or refill a medicine because of a lack of money. It's a big problem.
And I'll just add, I often give just a practical tip. So this doesn't solve the problem. This is just navigating the system. In an emergency room or in your doctor's office and you're not feeling well, especially if you're a woman, you're having difficulty advocating for yourself. You feel if you're being dismissed. I want you to ask for an ECG or an EKG before you leave. Just ask for that. Now you're speaking our language. Speak the language of the system. Now you have asked for something, and the doctor, the nurse, whoever's there, will have to think about that. And you won't be denied, and your insurance covers it. And now you have an objective piece of information that they need to review before you get dismissed. So simply ask for an EKG, ECG, speak our language. That simple request has now communicated tons of information to whoever is taking care of you in the emergency room. So just remember at least to just ask for that. And women in particular, we have tons of mammograms and pap smears. We usually don't have an EKG in our electronic health records. So ask for one. Now you're communicating and speaking the language of the system. You've just alerted them that you're thinking about heart disease, and you're letting them know that they should be thinking about it. And you'll have an objective piece of data that they have to review before dismissing you.
Thank you so much. I'm going to give the last word to our newly minted CEO, Mr. Aki Garrett. He had a question and said he would go last.
Thank you. My question is simple. So my mom always raised me with the quote, ounce of prevention is worth a pound of cure. And so I've always thought about what can I do proactively to prevent a heart attack, to prevent heart disease, right? And I think I would love to ask the panel, what are 3 things that each of us in this room can start doing in the next hour, the next 24 hours to prevent heart disease or prevent a heart attack, right? Outside of any genetic factors. I have Lp(a), found out about a year ago. So that obviously makes me, a higher risk for that. But what can we do as a community? What can we start to, let our colleagues know, our friends, our families know, to help prevent these things? Is it dietary changes? Like what are real practical, tangible things we can do to prevent, so that way we don't need to be cured, we just avoid the whole situation?
So I'll start, and just some things that are sort of off the beaten track. Get good dental work. Keep up with your dental appointments. There's a direct connection to heart disease. Get your flu shot. People who don't have flu shots have a higher risk of heart disease. The actual flu shot stabilizes your membranes and inflammation, especially if you already have heart disease. And then move, not exercise, move, because all the things we're talking about, digital health and AI, have also decreased our movement, our activities of daily living. For the most part, many of us don't even leave the house anymore. And think about that. That was calorie expenditure to get up, take a shower, to get dressed, to walk out, to open your car door, to get in the car, to put the seatbelt. All of that is energy expenditure. You get to work, you have to walk in, you got to go up the stairs, you walk to different people's offices. So we've removed movement from our life. So I don't really want to talk about exercise. I want to talk about moving, and we're moving less. And so therefore, we're also getting sicker as well.
Thank you, Dr. Lozano.
Know your family history. Talk to your family about their history, and team up and work together with your friends and with your family to talk about these things. Again, Rodney brought up a great point. I would not be thinking about PSA at a Knicks playoff game, but that's just me. I think that if you have those conversations with your friends and your family, it's going to be really important. Just like if you do those things and it's on everyone else's mind as well, you're not doing it alone. You're doing it together.
We have a 5-year initiative at BlackDoctor called Generational Health, and it talks about that exclusively as well. Having the conversations around the dinner table, having the conversations at the holidays, at the family reunions when you get everyone together. Talk about the family health. Talk about what happened to different relatives in your family and the lineage and what they passed away from it. That is going to give you a good indicator on what you have in your family and what you maybe need to look into. Dr. Ferdinand, you want to wrap us up?
Know your numbers. I've had patients who've had elevated blood pressure. The new goal is less than 130. Normal is less than 120/80. And their blood pressure is 140, 150. And I'll say with some alarm, Ms. Brown, your blood pressure's up. Oh, baby, it's been like that for years. The patients are often learned that their condition is normal. It's not normal. Let's be hunter-gatherers. Use sticks and get root vegetables and leafy vegetables, and every once in a while catch a fish. If we're really lucky, get a wild game that's lean and mean. And then when the sun goes down, go to sleep, get rest. Avoid the overstimulation of the modern society.
Bring it back to the basics. Bring it back to the basics. Eat well, get sleep.
I didn't mean for everybody to be hunter-gatherers. I meant live a more simple lifestyle.
Live a simple lifestyle. Eat right, get sleep, get water. And if your numbers are elevated, don't think of it as being acceptable. Right. You got to figure out what it's supposed to be.
Like a hunter-gatherer.
Like a hunter-gatherer. Thank you. We've got you. So thank you so much. A round of applause for this esteemed panel. This conversation so important. Thank you. Thank you. All right. So we're going to welcome Derek and Jade to share a couple quick things while we switch to the next panel. Thank you all.
All right. So incredible, incredible panel. We're here, as you can see in the program, we're doing connecting moments. We're connecting the dots for the day. And one thing I love about this panel, it brought back some memories of what my aunt used to say and still says to this day. Baby, you just got to tell it like a TI is. And I think that's what this panel did. They just told it like it is. And where's Dr. Ferdinand? From New Orleans? That's where my family's from. So I didn't hear the baby, lady. I didn't hear that in your voice, but I see you. I see you. One of the most incredible actionable steps. Everybody say actionable? Actionable. All right, y'all are getting better and better as the day goes on. Actionable? Actionable. Yes, one of the actionable steps that we talked about was garbage in, garbage out when it comes to your information, getting it from AI. You know, you need to check your sources. Where is that stuff coming from? And why are they saying it? You need to check that sort of stuff. Also, ask for an EKG or an ECG at your next doctor's visit. You know, this panel talked about, cardiovascular disease that, disproportionately affects African Americans, but it also, we had a lot of talk about Black women. And it just brought together a memory of mine as a hip hop head, old school hip hop. I don't know if any of y'all are familiar with the Jungle Brothers. That may be before some people's time. But they had a song called Black Woman. And it sort of sums up how Black women are at the heart of everything in our community. It says, Black woman, mother of the earth, Black woman, you gave me birth. You can truly see what's in me. You can help me be the best that I can be. You feed my fire when I'm on the wire, keeping me calm when it's getting higher. Sweet like sugar and hot like wine, always keeping you on my mind. You're giving me life, a new light to reach for, giving me so much more, so much. How could I ask for more? Keeping us tight when we're getting loose, the darker the berry, the sweeter the juice. Black woman, Black woman, Black woman. You all mean so much to us. And that's why this panel was so important to me, as my mother, she suffers from cardiovascular disease, but she is extending her life thanks to a clinical trial that she is currently on. So it's an incredible full circle moment for me and my family personally. Jade, to you.
Yeah, absolutely. How are we feeling about the day so far? Can we get a round of applause for our panelists, the panels that we've had? So before we continue on, we are going to jump into a break, just to really let everything set in before we dive into the rest of the day, because it is an impactful day and we have so much to continue to talk about. But during this break, I encourage you, I hope you took notes during that last panel and during the first panel, but to reach out to your family or figure out how you're going to have those conversations, because historically and just in general, we have a hard time talking about our health. We have a hard time being weak, especially as Black women, especially as Black men. We have a hard time being weak. So it's time for us to have those conversations where we're bringing those conditions to the forefront, the things that are concerning us, because we've heard it from our parents, we've heard it from our aunties, our uncles. We know that they're experiencing some things. We're hearing it. My heart felt weird this day, or I was out of breath. That's actually not normal. And we need to do something about it. So I think it's time that we start passing on the information that we're actually learning and making a change within our community. So I encourage you during these next 10 minutes to take the knowledge that you've learned here, take notes, send it in a text, prepare it for the next family reunion, Thanksgiving if you want to wait that long, and just start having those conversations so that we can see a change within our community. So I'm gonna be quiet. I know y'all probably hungry, maybe need a sip of coffee. So we've got some snacks out there and some refreshments, and we're gonna take a quick break, but we'll be back soon.
Test, test, 1, 2. Test, test, 1, 2. Test, test, 1, 2. Test, 1, 2. Test, 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 1, 2. Test, 1, 2. Test, 1, 2. Test. It is test.
I don't think it's on. It's not on? No, all chairs are being used. Okay, yeah. Hello? Okay, just stay right here. Hi, Dr. Hampton, stay right here. Hi, everybody. Are we ready? All right, everybody. We are getting ready to go into our next panel. So please take your seats. We're still stopping at 12. Are you guys having a good time? Yes? All right. We are about to have a great conversation. So for those of you who don't know me, I'm Dr. Ashanti Carter, and I serve as the Chief Medical Liaison to BlackDoctor. And as Dr. Toyshay stated when he said, "Oh, welcome home, Dr. Carter." Yes, I used to work on the 6th floor here. So yes, as a staff person, former staff person of GW, I'm also an alumna of the George Washington University. So yes, here, yes, indeed. So our battle cry is raise high. So when I say raise, you say high. Raise, raise. When I say raise, you say high. Raise, raise. All right, I love it. Yes. You're all awake. So this is great. So this next conversation is all about clinical trials or clinical research. So did you know that there's a stat of individuals who participate in clinical trials? So tell me, yeah, getting back to my days of teaching, what's the percentage of Black folks who participate in clinical trials? What's the percentage? What? Who? Wait. I heard it. Say it loud. 3. That's low, you guys. So what does that mean about clinical trials and the medications? Right? Right. So it's all about equity. So the wave of the future, it's still in clinical trials, you guys. And we are doing some great work at BlackDoctor, right? Or blackdoctor.com, not org, right, Aki? Yes. So for this next conversation, I would like to bring up our esteemed panelist, Miss Ricky Fairley. Come on, Ricky. All right. How are you guys? Yes, so I'm going to give her the mic and she can introduce her panelists. But you guys, I want you to listen and really try to learn about clinical trials and clinical research and why it's important because, hey, if you're not at the table, you're on the menu. Do you want to be on the menu? No. All right. Here you go.
Thank you. Everybody having a good day? Good morning so far? Kind of, I don't know which way to turn. Right, my back. So I have an awesome panel who I love. They're my friends, and I'm going to introduce them. You guys, come on out. So this is. Go ahead, sit. I can't fit up there, so I have to stand over here. This is Dr. Regina Hampton. She's my doc. This is Latoya Bolts Johnson. She's my blessee. And this is my new friend, Phoebe Daniel, who's from Amgen. And this is my dear friend, Clayton Yates, who is an amazing researcher at Johns Hopkins. And I love your title, right? Clayton is the endowed, the John Lewis endowed professor at Johns Hopkins. So pretty cool. So he does a lot of research. So I'm happy to be here with you. And I'll just start by saying I am really alive because of a clinical trial. I had stage 3A triple negative breast cancer. I did all the stuff, surgery, chemo, all the things. It came back in exactly a year. And I fought for myself to to do a clinical trial. And I'm here. My doctor gave me 2 years to live. I'm on 14. So this is my God job. This is my God job. And we can do all the things and help people with cancer and do all the advocacy. But unless we change the science and advance the science, we're going to keep dying for all these diseases, right? And so what does that mean? That means we have to participate in clinical trials. So you guys, I'm going to let you guys all just kind of do quickie introductions, and then we'll sort of get into the questions. But these are all my people.
Hello. Hi, I'm Dr. Regina Hampton. I'm a breast surgery oncologist with Maryland Oncology Hematology here locally in the Maryland area.
Hi, good evening or good afternoon, everyone. My name is Latoya Bolts Johnson. I am a breast cancer survivor, stage 3C triple negative breast cancer. I'm also a physician assistant and mom and thriver.
Hi, everyone. I am not Dr. Osa Isley. I believe she was on the screen a little bit earlier, but my name is Phoebe Daniel. I am the Strategy and Data Insights Manager on the Representation of Clinical Research, or RISE team over at Amgen. And our team is really focused on ensuring that disease burden is matching the clinical trial populations in our studies. So I'm really excited to be here today with our other panelists to continue this conversation.
Hi, I'm Clayton Yates. I'm at Johns Hopkins. As Ricky said, I'm the John Lewis Professor of Oncology and Pathology, but also serve as Director of Health Translational Disparities, as well as Global Health Equity. And for almost 19 years now, my lab, as run a basic science research lab, has exclusively focused on molecular targets and why disease is so aggressive in individuals of African ancestry. And I'm really proud that we're now translating some of those basic discoveries into clinical interventions. Actually, I was at Tuskegee University for 17 years, and I moved to Hopkins about 3 years ago because I felt it was time to implement these into people in the clinical trials. And so we're now designing trials at Hopkins that are intentionally designed to target molecular targets in people with African ancestry and African Americans.
We'll talk more about that in a second. So a few years ago, I wanted to understand, I'm a marketing person by trade, I work at Coke, and so I wanted to understand why Black women aren't participating in trials. Like, why aren't we, right? And everybody wants to blame it on Tuskegee and Henrietta Lacks and all the science. But the research didn't show that. Those were kind of clouds in the atmosphere. But the main reason why Black women don't participate in trials, and I think it goes across the board for all people, is what? What do you know? Doctors don't invite us. We are not asked. Why is that? Bias, racism, whatever the things are. They don't want to lose a patient. But that's number one reason. Equally as important was another reason. Anybody know that one? Fear of the unknown. I'm going to get the sugar pill and die. I don't want to be a guinea pig. So that said to me, as a marketing person, people just don't understand what a trial is and how it works, right? They don't understand it. I mean, if you called somebody on the phone right now and said, do you know how a clinical trial works to anyone in your family, would they be able to answer the question? Right? So we figured that we had to break down the science and explain it to people in words they can spell. Hello, from a voice of trust. So we launched a campaign 4 years ago called When We Trial, and we've now signed up over 33,000 Black women into our clinical trial force. But that's not enough. that's not enough. We all, we talked about generational health. We all need to be talking about clinical trials at the kitchen table with our families. That's when we're going to get better. So let's start with you guys. I think, you guys, do you think there are any other misconceptions besides those? No, really. And so, what do we think we should be doing about that? So do you think trust?
I will add to that. Yeah. I think also some of the institutions that perform these trials don't reach out to community physicians, because a lot of times patients of color will come to community physicians, and I am one, but a lot of times they won't partner with us where the people are coming to. They're not always going to university institutions. So there needs to be more partnership with providers in the community.
Oh, I echo that. I'm at Hopkins, and I've been advocating for that as well, coming from a small institution like Tuskegee, since I've been there. Sometimes the academic sort of industry sort of led sponsors go to because of the research part of it. But a lot of people are still being cared for in the community, and they're just completely missed. So I call it like we don't know what's out in the real world when we do these trials, so we can actually translate it to the larger population. I absolutely 100% agree with that.
Toya, tell your story.
Yes. Well, as I stated, I'm a stage 3C triple negative breast cancer survivor. I was diagnosed at age 36 in 2021 with no known family medical history while I was breastfeeding. I felt my own lump. My doctor ordered mammogram, sonogram. From the very beginning, I had to fight. And I'm fighting as a healthcare provider. The radiologist did not want to perform the mammogram, stated I was too young. Had the mammogram and sonogram, fought for it anyway. I was misdiagnosed. I was misdiagnosed as having a galactocyst or benign milk cyst. Repeat sono in 60 to 90 days. Gratefully, it was a chief radiologist who performed the overread, thought that it looked suspicious, had a biopsy. It was a Friday when I had the biopsy. I was told I would get a call Monday or Tuesday with the pathology report. Well, instead of receiving a phone call, I received a text message on my cell phone while I was at work, working with patients in the ER, that showed that I had triple negative invasive ductal carcinoma by text message. Yes, ma'am. Yes. I had to leave work. My world was just rocked. I thought it was a mislabeled specimen or something of that nature. The next morning, I received a phone call from a radiologist who was very nonchalant, no compassion whatsoever. Yes, this is your diagnosis. You'll get a phone call from a nurse navigator. I was just in a state of shock. I had 3 babies. I nursed every one of them. I was still lactating. So it was just, my world had turned upside down. Fast forward, I'm starting all the things, neoadjuvant chemo, followed by, mastectomy, radiation, and more oral chemo and immunotherapy. But during the neoadjuvant phase, I started looking for clinical trials myself. I also found out that my doctor withheld immunotherapy from me, Keynote 522. He did not prescribe immunotherapy for me. When I asked him why, he turned to his screen and said, "Oh, it's not on my NCCN guideline checklist. That's the reason why you didn't receive it." In addition to that, I have been sending him my own studies that I have been finding on clinical trials. I knew the importance of it, but I also knew in that moment that if I'm fighting for this, I can't just imagine what someone without a medical background and the hardships that they're facing in this navigation. So I fired him. I got another doctor. I was enrolled in the clinical trial right here at Georgetown. And I needed to be enrolled in the clinical trial because I needed to understand why I was being faced with such a deadly diagnosis at 36 years old with 3 little girls who will have boobs one day. So this was my way of building my medical trust fund for my children. It's no different from building your 529 for your children. I needed my Black body to be studied. I needed to understand why this was happening to me. I needed my biological data to be deposited somewhere so that my genes can be studied so that one day maybe we can get to a preventative measure for my 3 girls who will have boobs. So, I say all that to say that I had to come forward as a patient advocate. This wasn't something that I set out to do. it just allows me to serve a dual perspective to be able to speak to clinicians, but also advocating for patients because it made me see things from a different lens. But now I've been out of treatment for 2 years. I participated in the clinical trial, and I just have to live every day to the fullest.
Thanks, you guys, and her little girls are precious. Clayton, do you want to talk about what we talked about earlier, just what you guys are doing and how you're looking at research differently now and how important that is?
Absolutely. Over the past, I think, at least my career over 20 years, there was an explosion of not only trying to understand the access to care as well, but also what is the basic biology. So if we start thinking about drug development, it actually starts in the lab, right? Where the question of what is driving that disease. Those questions are really important because as we fast forward through the research continuum all the way to a clinic, those questions actually end up into what drugs are being targeted. So as a basic scientist, we think it was really important for us to actually ask those basic questions early as we're developing the biology. Are there differences between where cells from an African ancestry individual respond differently to certain therapeutics? But fast forward 20 years now of basic science discovery, right? It's time for us to take that knowledge. There's a collective body of knowledge in the literature. I do cancer, prostate and breast cancer, so I'll focus on those, that we now think that we have targets that pharma can exploit. For example, inclusion criteria for a certain drug. We now know if that gene is overexpressed, right, in a certain population, that should be an inclusion criteria for that particular patient, right? And then as we're discovering new drugs, right, based on new targets, then we fast forward those as well. And so my role at Johns Hopkins is to do just that. So I've been there 3 years. There was I thought was a really cool study for prostate cancer patients at Johns Hopkins being pioneered. It's called high dose testosterone, a batch study. So in prostate cancer, it's driven by testosterone, right? Just like we talked about hormonal therapy. And so hormonal therapy is the standard of care. However, at Hopkins, they actually, when men stop responding, they give high dose, super physiological levels of testosterone. It does almost just as good as taking away testosterone with the standard of care. Black patients were being enrolled in the trial. We mirror that those patients who respond better to that Black therapy have gene signatures that are more prevalent in the Black community. And now we're opening up in our first trial and over-enrolling African Americans for this very life-saving study that is going on at Hopkins. And so that's just an example of matching biology, because we know we're in the era of precision medicine, with what we already have available and making sure the people in our community receive the best in the standard of care, best possible care as possible.
Incredible work. Dr. Hampton, and we know also that Black people tend not to get genetic and genomic testing. They don't get biomarker testing. It's I think it's about 40%. And that dictates all the precision medicine that we need in cancer. So Dr. Hampton, I know that you just did a study on genomic testing. And can you talk to that a little bit?
Yeah, great point. I really believe I've treated mostly African American and Latino women in my community. I'm in Prince George's County. And so genetic testing has always been at the forefront. I still find that a lot of us in our community don't want to get genetics. We're afraid of where that information goes. But I think when the counseling comes from someone that looks like them, I think it can make a big difference. And not to say that my white counterparts can't do it. I just think it comes differently, because I can sometimes be like, girl, get it together. This is what we're doing. Versus my white counterparts can't really approach a patient in that way, but that's how I'm able to get them. I have been doing a registry trial called the FLEX trial. And my goal, just as everyone else, is really trying to get more Black tumors in there. And what we are starting to find is the difference. And I'm starting to get an aha moment in that our tumors tend to be what's called luminal B, even when we are estrogen and progesterone positive. So in breast cancer, when you have an estrogen and progesterone positive tumor versus unlike what LaTanya had, those patients are eligible for a hormone type of treatment. But what we're finding is that in Black women, many times our estrogen receptor is not that functional. And so you have to add chemotherapy on top of that, in addition to the endocrine therapy. So I think this work is exciting. I'm excited to get more Black tumors in there so we can try and find these answers. They're also starting to look at triple negative tumors as well. A lot of genomic testing won't allow triple negative tumors to be in these or even to be tested. And so we're starting to find that not even all triple negatives are the bad actors. But can we try to figure out, well, who are the bad actors and who are the ones that we can say, you're going to get your treated, you're going to have a good response, and we know you're going to be okay for the next 20 years of your life. So a lot of exciting things. But again, I think patients have to be asked, and we have to get the right clinicians who are involved to partner so that those patients can be asked.
Vivi, can you speak to, thank you, Dr. Hampton. Thank you. Vivi, can you speak to what Amgen is doing with your RISE project and just in clinical trials in general?
Yeah, thank you, Ricky. And thank you so much, Latoya, for sharing your story and also for all the work that's been done prior to when clinical trials already come into focus. As I frame this discussion, I really want to say, to begin, 70% of clinical trials are run through industry. So really, it's a public health imperative when we say there's an underrepresentation in clinical trials. And so the RISE team here is a step after what you were describing, after we find those biological markers, after we figure out what that is, after we build that database specifically for the people that we're talking about here today. And how do we get, like you were saying earlier, these people into our clinical research sites? And one of the things that we talked about earlier today in this panel is actually how a lot of the studies that are running right now are in large academic centers. And the primary goal of our RISE team right now is currently figuring out how we can transfer that or link them to community-based sites. How do we link them to the community health physicians who see these patients on a daily basis, who see these patients just regularly, who have access to these patient populations? And so we are really excited to be launching this program called Research Expansion and Access to Community Health Sites, our Amgen REACH program. And this is specifically partnering with community health centers, partnering with them to see if they have the logistics to basically offer sites to community members. And if they don't, how can we support that infrastructure? How can we support that capacity building so that these community members have access to these clinical research sites? And with this, we're really hoping to improve that access because, like you were saying, Ricky, it's not really an issue of are they willing to participate? It's are they being asked? Do they have an ability, a facility to go to that's not 3 miles away? I mean, that's 3 hours away or 4 hours away. Because, I mean, GW is a great campus, but it's an hour 20 away from me. It's 2 hours away from you. And so it's not like it's feasible every single time for someone to come here for their clinical research treatment. And so at Amgen, we're really excited to be launching this program in partnership with our community health physicians to really improve that access, improve that availability of these trials to community folks across the spectrum.
Great, that's great. One of the things that we're doing at Touch is helping companies like you, all the pharma companies, develop the marketing materials. I call them marketing materials for trials because most of them suck. Sorry. I have to tell you your baby's ugly. And most of them are very scientific and not very user-friendly and don't embrace patients. And guess what? I wear hearts a lot because we're in the love business. That clinical trials are about love. Patients don't do clinical trials because they want their molecules tested. Patients don't do clinical trials because they want to advance science. They may have that sort of as an altruistic goal, but they do trials because they want to have another birthday. They want to see their kid graduate from college like I did. They want to have, take care of their babies. And so we have to think about how we talk about it, how we talk about them, and where we conduct them. And it's really, really important to think about the people that are involved here, that we're talking about people and their lives. We're not talking about science. Got to approach it differently. We also provide navigation to our patients in the trials. And we have a 24/7 navigation team. And all of our navigators are Black women. They're 24/7, meaning you can call them anytime when the cancer center closes at 5 o'clock. You can call our navigators, and they all are survivors of the disease. And so we're now expanding that actually to all diseases because it's so important for a patient to be able to pick up the phone and not get that thing, oh, if this is an emergency, call 911, and then wait to be triaged for 10 minutes before they can talk to somebody. We provide that service. So Latoya, you were going to say something?
I was just going to say that I have been trying to focus, and whenever I get a chance to, I think that, there has to be some retraining to the HCPs as well, because I know for myself personally, even I was sending like NCT study numbers to my oncologist, and I was still being dismissed. So yes, I was not asked, but for someone like me who's like showing interest and I'm still being dismissed, I just think that there has to be some type of retraining and remodeling. Just probably from getting the young doctors, medical school level and onward, because y- y- I think there has been assumptions made all the time. Yes, I had to drive about an hour away, but I was willing to do that. But don't always assume that okay, they're not going to drive or they don't have childcare or whatever it may be. I think the first step is just to ask. It needs to be like a vital sign whenever they're being triaged. It needs to be a vital sign, whatever it may be. In clinical trials or for so many different disease subsets, like just ask. And if there is a lack of comprehension about it, then that's when you have a multidisciplinary team approach to educate that patient about the importance of clinical trials and just breaking down those barriers, because there may not just be full understanding of the trial.
I think clinical trials need to be a upfront consideration as soon as you're diagnosed with anything. That should be an option.
Absolutely.
So we need to make that happen. So you guys, what can we do? We're in this mess. We need better science. We need better drugs for Black people. How can we fix it? I mean, I think we're all doing pieces of it, but is there something we could all be doing together to communicate better? And I mean, thank God for BlackDoctor's platform to be able to talk to a lot of people. And so we're here. Let's figure out what can we do? What can we do? Anybody want to go? Go, Clayton.
All right, I'll take it. I'll take it two steps. So from my point of view, in fact, and Rick and I, we've had this conversation where we say we need new drugs. I actually think we have a number of drugs, but we don't know who and when to target those individuals appropriately, right? So mirroring the science with the clinical translational data we have, understanding genetic backgrounds in our precision medicine era, I think is really key for us. And then the second piece, I think where you mentioned, we have to be able to communicate that to our community. It's essential that the community gets that there are people out there, such as everyone on this panel and pretty much everyone in this room, that are trustworthy, right, and are looking out for you. And to be able to have those resource hubs where people can go to get that trusted information so they can help guide their care. I cannot tell you how many people from our community, I think it was a person on the panel before, that come to me because they were confused by what their doctor said. And I'm not involved in their care. And it's happened at GW, it's happened at Georgetown, it's happens all the ways. Because I've tried to become a trusted member or participant in the community to help explain what is happening in care. So I think those two translations will help disseminate as well as be able to design therapies that are more effective for our community.
I can go second. And it's actually building really heavily on what you were stating, but from an industry perspective, right? We don't have the best track record of trust. And so a part of this, right, for us is communicating directly with the trust makers of the community, communicating directly with the community physicians that are trusted with these patient populations, and understanding what these gaps are so that we can really identify where we can step in to be the greatest resource to you and to provide that access for you and the patient populations that you serve. And when I think about this, I think about all the different things that we talked about today, how everything is kind of in silos. And so in a lot of ways, we're all doing this work to propel this piece of representation, this clinical research to the communities that need it the most, because again, like Ricky, you were saying, clinical research should be a core tenet of our health care. And a part of making sure that that is a possibility, understanding that there are organizations that do this work across the continuum, from the beginning to getting those drug targets to the actual clinical research care delivery model. And so I believe there was a colleague here from Novartis who was talking about the community engagement and community liaisons into different communities. Amgen has that too with our Rooted program. And so as we're thinking about how we can do this, it's really understanding that so much of this work is already being done. And individually, there's this quote, individually we are one drop, together we are the ocean. And so as we're propelling this forward, it's understanding that and communicating across the continuum. This is the work that is doing, partnering across this continuum to make sure that the changes that we are pushing forward are actually seen by the patient populations that we are trying to reach.
Well, I'll just keep it simple. Ask, don't assume, offer it to everyone, and make it very relatable in plain language terms. That's what I got.
Awesome.
Yeah, I think a grassroots approach, I think there's two things, one on the patient side, one on the provider side. I think on the provider side, I think it's, reaching out to community providers, helping them to get, NCI, get them an NCI investigator license, which is pretty easy to do. But I think, many clinicians, if they're busy taking care of patients, they don't really know to do that. And I think if we could help them to do that and provide the resources for them to be able to do the research, I think that can go a long way. Then I think on the patient side, I think it's kind of walking them through. I found that because I've been able to get patients into a registry trial where we're studying their tumors, not necessarily studying them, and they don't have to take a medicine. Once I get them into that, when they go to see the oncologist, they're more open to want to get into a trial. They're like, oh, well, I'm already in a trial. I'm in the blah, blah, blah registry trial. So then they're more open and their ears are open. So I think it's a two-pronged approach, because I think we definitely need to get more of these Black tumors studied to then help industry to be able to come up with medications that will work for these tumors.
That's awesome. That's awesome. We just started a program with pastors, and we developed like a toolkit for pastors. After you pray, what do you say? Because the first thing women do when they go get diagnosed is go to their pastor. Can you pray with me? But then they don't know what to say. So we've developed a toolkit all about clinical trials and to direct them to clinical trials. And BlackDoctor has a great resource on the website to find clinical trials. We have two websites where you can source trials on, whenwetrial.org and navtrials.org. If you want to find a trial or help people find a trial, and we do whatever we can to help get them into the funnel and then navigate them through the process. But I think it's just sitting down with your families, sitting down, understanding your family, her story, your family history, talking to both grandmas on both sides or whoever's around, and understanding your family history, what you're up against, and knowing that, we are all at risk. Everybody has a cancer story. Everybody has a heart disease story. We can't, we're not going to change anything until we all take this responsibility to do it ourselves. Our tagline for this is, we are the science we've been waiting for. We in this room are the science we've been waiting for. We have to make it happen. So thank you.
I think helping to get patients' history, guess what's coming up? Reunion time.
Yes.
And everybody's family going to have a reunion, and everybody's going wherever. Get index cards. BlackDoctor, y'all could do this. Get some index cards and hand these out. And I tell my patients, y'all take index cards to the cookout, collect them, and they don't even have to put their name on it. Somebody take that. Somebody put it all together, and AI can help you do that, and then distribute it to the family. So at least people know, 3 people have hypertension. 4 people have been diagnosed with colon cancer before the age of 40. I think these are simple grassroots things that we can put in people's hands so that the cookout, then we can use that to get the his and her story.
Yeah. Anybody else? Oh, we have a question? We take questions, or we allowed? Okay. Go ahead. Come up here so we can hear you.
First of all, I want to say thank you. Thank you for your story, and thank you for fighting. That's one. My name is Dr. Carmen Saunders Russell. I'm an associate professor at Cal State University, Northridge, and I'm a pracademic, a researcher, and a scholar. And I am also a mammographer. And I am angered and hopeful by the story. Angered that you got a text message. Angered that you got it on a Monday without anyone speaking to you. I would never, ever do that as a mammographer. I'm saddened by that. What I'm hopeful about is that I currently teach undergraduate and graduate students in health administration. And I think that those are the people that are left out of the conversation right now. The leadership, those are the individuals we need for buy-in to bring those programs into the forefront and put them as accessible to the community. So I think, and I would love to speak to anyone to see what kind of curriculum I can hopefully bring in to that aspect of programming so that now that those future leaders and administrators that are out there working with patients can now also empower them when they go in to speak with their doctors, because it's the interdisciplinary approach that we need. And I want to be a part of that. But thank you for the fight.
Awesome. We will definitely follow up with you because the more we can communicate, the better. You know, in my ideal world, if I had a lot of money, I would build a beautiful Victorian house in every Black neighborhood where you walk down the street, you open that wrought iron gate, the beautiful Black grandmother meets you at the door. She takes your 3 kids into the playroom, feeds them spaghetti. She takes you into the treatment room. She sits you down in a cushy chair, gives you a cup of tea with mint from her garden, and she turns on Luther Vandross and gives you a shot. Because we have to bring the love to this. We have to have a different conversation. We have to bring it to our people. We can't expect them to come to it because they're not being asked. Whatever we can do. I think we have a few more minutes for questions. Anybody else? Oh, come on over. Here, come to this one. Okay.
Thanks so much for that excellent discussion. My name is Isilma Fergus. I'm a cardiologist in New York and a member representing Association of Black Cardiologists. This is so important. The clinical trials that are out there are very sparse when it comes to the representation of Blacks and Browns. And when you look at the demographics in this country, about 13 to 14% of us are Black. But when you look at most clinical trials, you're seeing 5% or less. So a lot of times, how can you actually state that these medications and these treatments actually work for our communities at large if we're not represented? But one of the issues is that we need to have more people engaging in clinical trials. And I actually happen to do clinical trials, but I'm at an academic institution. We need to get out into the communities where people are practicing and seeing the patients. Because I'll tell you one thing, you talk about trust and mistrust and the Tuskegee. There's still a lot going on out there that people don't feel comfortable enrolling in clinical trials. Look at how that young lady was treated. That is abominable. So people are going to feel more comfortable enrolling in clinical trials with their primary practitioners in the community. So it's an opportunity for organizations such as the BlackDoctors.org to engage, and ABC, because we've done that as well, to engage with companies that want to do the clinical trials and then support the people in the community to be able to enroll more. So I'm just putting that out there. This panel is important. It's an excellent opportunity and very timely to get involved with the organizations helping to support some of these primary practitioners to do the studies. Thank you.
Any chance anybody has to educate at the kitchen table, at Starbucks, wherever you are, who was saying, what's your PSA? I asked people that all the time, when was your last mammogram? But we all have to do it. We are the science we've been waiting for. Any other questions?
Yeah, thank you. I think the idea of bringing the research closer to the community is probably a really big opportunity. And I'm wondering if there's a way to have partnerships where community centers, CVS clinics can work with sponsors of clinical trials to find a way to make these local sites, research sites, even if they have to partner with the big institutions, but to find a way to bring in those diverse communities into our trials. There are models that have been done where a big academic center has, satellite clinics, and they incentivize the doctors to enroll on clinical trials, but they make it idiot-proof, where you just have to click a button, click, 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 and they provide them with the resources. So I would really encourage us to try to find those types of opportunities. Everybody can't go to Hopkins or Emory or Children's National.
Right.
We live in our little community zip code. We have to find a way to get what we need closer to our homes. Thank you.
I just wanted to comment on that really quickly. So I think that is a new sort of emphasis for Minneapolis. We are having those conversations at Hopkins now. We cannot see everyone in the clinic, right, in the hospital. It also costs too much for its cost. And so we're having those conversations of how we translate it. We're actually recruiting faculty now who are specializing in bringing clinical trials to the community in the home as well. And so those conversations, I know Mayo, Hopkins, and all of those, we're forming a tripart collaboration to have those. So we're thinking about those, but I also think it's an opportunity for this organization here to sort of be a part of that, because all of those conversations don't necessarily reflect the complexities of our community when these are being designed.
It boils down to design. I know, and Dr. Hampton's a community doctor doing it in the community. So we need more and more and more of it. But also we need to be talking. That it? We're good? All right, so check the breast that you love. I know you have a pair.
Wow. Jade, another important power-packed panel. What do you think?
Absolutely. You know, I love the clinical trial conversations. I love how we can bring up those statistics and talk about the lack of representation within the trials. But I also love that one of our panelists mentioned it's not that we don't want to, it's that we're not asked. It's because it's not accessible. So there are things that are in the way that are keeping us from participating in those trials. It's not that we don't want to. It's not that we don't want the care. There are things in our way. Derek, what do you think?
I thought, man, they dropped some gems that I wrote down. Like, one of the things that I never heard this term before, but it's an actionable term. Everybody say actionable.
Actionable.
She said a medical trust fund. She was investing. This is her medical trust fund, investing in her health, deciding to go ahead and find that clinical trial for herself and for her babies. So it was incredible. Also, I heard about the cookout questionnaire. That's what I like to call it, cookout questionnaire. I'm going to use that at the next family reunion. You know, when they pass the greens and the barbecue and the ribs, you know, be like, hey, pass this question too at the same time. So I love that. Are we about to break for lunch? We are. But before we're about to break for lunch, just two quick important announcements. One, don't forget during the lunchtime, please make sure you visit the Novo Nordisk Live Unlimited table. It has some incredible information about sickle cell, which is affecting so many of us. So please visit that table to my right, your left. Also, for lunch, while your bellies are full, you want to remember Bayer. Bayer is the sponsor for our lunch, so please give it up for them. Bayer, their mission is simple: health for all, hunger for none. So they made it possible for us to have lunch out here today. So lunch is right behind us. You can go out this door here and grab your lunch, commune with each other, and we'll be back after lunch. Thanks so much.